Good morning. This is the very last lecture of level 3. You're ready to move to level 4 right after your last test and your final exam and your ATI comprehensive predictors. So I'm going to share my screen and we'll move into the exemplars in grief. All right. Okay. The grief exemplars, this is a kind of sad unit, so bear with me. It might affect you if you've got things going on in your own life or you've had this happen to you. So just allow yourself to grieve and go with it. It is important that we talk about it. It's also important you come to terms with things in your own life as you work to help other people. So we're going to be talking in the first piece of this is the exemplars are if the family has a prenatal diagnosis of a congenital defect. The first part of this slideshow is all about sudden infant death, stillborn children, congenital defects in children. So these are things that are difficult to talk about and yet happen to patients, and we have to be prepared to understand what and how we deal with them. So if the parents are pregnant, obviously, and they have prenatal care, then it's often that we get a diagnosis. We can see in ultrasound or through amniotic testing that there's a DNA problem, or for an ultrasound, we might see a congenital defect, or we might see that the child's dead in utero, or we might, there's all kinds of different things that we see. If the parents have any of these kinds of problems where there's a real grief issue because they've lost either a healthy infant or an infant at all, then they might experience some guilt, and that can bear on their grief. If they feel responsible for the things that happened. Another thing that'll come up is that as that child's first birthday, or if this is the time that they would have been sending that child to kindergarten, the waves of grief may return for these families. The loss of a child is one of the most significant losses we can experience in our life, and one of the hardest to grieve and hardest to get over. If the child has a congenital defect, that defect might impair the maternal-child bonding process. If mom is having trouble accepting the loss of the perfect child and seeing this child with the abnormality that they have, in some cultures, that abnormality is deemed shameful to the family. So that can be really difficult for the child, because the mom and the dad will have difficulty bonding with them. All kinds of things affect, and that should be an affect, the parents' response to loss, and that can be their culture, their history, if they've previously experienced things, how much guilt they feel, what kind of relationship they have, their support system, if they live in an area or have the ability to access help for the child and treatment and cure. So all kinds of things will affect this. And every time a developmental milestone is the time that child would walk, talk, or go to kindergarten. So a child who has a congenital abnormality might be developmentally delayed, and the parents might grieve, oh my gosh, my child should be walking and they're in a wheelchair, or my child should be talking, but they can't articulate speech. So these kinds of things are going to bring up grief waves, as we spoke about. We want parents to realize we're going to get this child to the highest level they can learn and the highest level they can reach. And they need to understand what the optimal outcome for their child is. This child may never walk. This child may never read. This child may never interact well in social circumstances. As that child matures into adolescence, and some of our congenital abnormalities in our genetic abnormalities, genetic mutations and things, can cause children to have precocious puberty, where they enter puberty early. Sometimes sometimes kids with developmental disorders are hypersexual. So adolescence can become a challenge. They still may crave independence, and yet they won't have it. And so the parents are going to be dealing with a lot of issues and things that they expect or don't expect to deal with. They also have to make a lot of decisions. If the child's going to outlive them, and they need special care, they have to make plans for that child after their death. Where is that child going to live? Who's going to care for that child? If the parents are old, it's too old to care for that child, or cannot maintain the level of care that child needs because of their own health and aging issues, then something has to happen to that child, and they have to have a plan in place. And so all the anticipatory grief coming up to the delivery and the ongoing waves of grief that happen throughout life as they realize what's going on, if it's a congenital defect, if it's a stillborn child, or a child that has sudden infant death, then it's just going to be the developmental stage. Like, when this happened for this kid, what I'm grieving because I lost my child at this point. Everybody else's child is going to prom. My child should be going to prom this year. So it's kind of different depending on if they have a living child with disability or if their child has died. The kinds of grief may be a little different. And remember, if a child's born with special needs, we're going to sweep that child away to NICU. And so that separation is going to impair bonding alone, plus the birth of a less than perfect child, which can impair bonding. So there's a lot of things that impair the grief process as parents face these issues. Parents of children are often young. Most of the time we give birth between 18 and 30. 20-year-olds are mature, but they're not, they haven't had life experiences, and they might have just recently moved away from their own homes. They might just be developing a new relationship that hasn't been challenged and tried, and so they don't know how it will happen. If the age of the parent is younger than 20, they're still in adolescence. They haven't fully developed Piaget's frontal lobe and all of his theories about maturity, and Piaget and Erickson both. And so this child has still got a desire. They're still figuring out who they are in society. If they're a teenager, they have that invulnerability. It can't happen to me. My child will be perfect. My child will be the best. And then they have a less than perfect outcome, and they don't trust adults. They don't trust situations. They don't trust what people tell them. So they're already experiencing so much on their own, and they're in a place where they may not trust or rely on adults well. They would trust and rely on their peer group, who may not have accurate information. So it can be a really challenging time when something like this happens in adolescence, and yet teen mothers are high at risk for some of these problems. And we talked about the difference between men and women grieving. Women are grieving differently, so the mom is certainly affected. Dad can be too. We don't want to rule the father out of any of these circumstances. Dad will grieve the loss of that child just as the mother will. But mom is an intuitive griever. We reach out to people more. We accept our emotions more. But we don't always show emotion or talk about our mourning and grief, and it depends on the culture of the person. But men, they're stoic grievers, where women are more emotive. So we need to understand that it's different and unique for each person, I realize, but we talked about, in general, women need to process verbally, and men are going to be more stoic, so they're going to need support, and they're going to need to have outlets to deal with their grief. And we need to be predictive of that, so we can be ready and prepared with support for that, for a man who's having trouble dealing with grief. Or if a woman is a stoic griever, might have the same thing. Family dynamics can certainly affect this. In-laws, grandparents say things sometimes they don't mean to. Sometimes in-laws don't have a good relationship with the mother or the father, and so they may cast blame. There may be a distrust in that relationship. So you need to be aware of those interpersonal connections that may be going on. The support may be strong, or the support may be fractured and discordant because of relationships. You also have to realize what level of socioeconomic status this family is at. Teen parents are generally lower socioeconomic status, unless they've got gobs of support from parents and other people in their life. Most teenagers don't have middle-class income. So if it's a young adult, even 20s and 30s, they are just getting started, they may not have good availability of resources, and they may not know where to look. As people mature and they have life experiences, they get more understanding of what's out there. Sometimes a 22-year-old doesn't understand what resources are available. And so we need to be available as a resource person to know what's in our community. If you work in the world of young families and you're dealing with young families in whatever capacity of nursing you choose to go into, you will develop a series of social supports that you can make referrals to based on the community you're in and the population you serve. We also always want to, again, go back to that patient's cultural and religious values. There may be very specific things that have to happen. That infant that's stillborn may still need last rites. That may be very important. A baptism of that baby before we bury it may be very important to the parents. We also need to know that they are going to have their own cultural mourning rituals, and we need to be prepared for whatever that might be. And sometimes we don't deal with things. We forget about those cultural things when it's an infant because we're worried about sending this off to the lab, or does this baby need an autopsy, and so we need to be very aware of making sure that the parents' needs are met. And if we have to do things that are going to be against the culture that they're within, if the law requires us to do things that are against the culture they're in, that we have a way of explaining that to the family, and that we communicate that to whoever we need to convey that information to. And we're going to usually work within the parameters of the hospital. So the case manager may be communicating with the forensic pathologist and let them know, hey, this family is Jewish, this child needs to be buried as soon as possible. That there's certain things that may or may not be allowed. All right, congenital defects are defects that happen in utero that are not based on genetics. These are things that happen developmentally in utero. You've already talked about that, I'm sure, in human development. The things I've shown you in this picture, there's a cleft lip, there is a spina bifida in the middle, and then on the far right is a club foot. Now, these things all require special care, and I don't know how much you get on congenital defects through the course of this program. I don't know where they fit into the concepts, and I apologize for that, but if you haven't had them, I'm going to briefly say, hey, cleft lip is surgically correctable. It's a series of surgeries. The child can have a cleft in the lip and in the palate. You can see where this might make it difficult for this child to suck at birth. So nutrition, there's some very specific nutritional interventions. We use special lamb's nipples that are longer, that go back to the back of the hard palate to enable sucking. We have prosthesis that can be put in to help the child with feeding. This child will have speech difficulties. They'll need speech pathology. They will have dentition problems when their teeth come in, so they'll need dental specialists to work with them. They'll need orthodontia, as well as sometimes some prosthetic work to make their smile look better, their teeth look better as they age. This child could have a lot of developmental concerns. It's going to take several years for all of these things to be healed and corrected, and they'll always have a scar. And so it can be a body image self-concept issue as the child begins to grow up. Especially you get to high school and a little girl with a scar on her face might have some, oh my gosh, I don't look appealing, or a boy too. And so all those things we'll need to be aware of, and the family will have to understand all the special needs of this child. This is much, much more common in South America than it is in North America. Happens about 3 times the rate, sometimes 4 times the rate in South America than it does in North America, interestingly enough. But there are special groups that can provide support for patients, and there's dentists that do gratuitous care for these children that need work. So there are support groups for them. And sometimes it can be a bonding problem. You hand the baby to mom and they're expecting this perfect little baby, and they have a child with a hole in the front of their face. And so it can be a shock to the mom and the dad when it first happens, and they'll need preparation. The spina bifida patient, what you're seeing on that child is a meningocele, so the bulge coming out the spinal cord in the back. That's actually a sac And through that sac, in that sac is spinal fluid. And if it's a myelomeningocele, there's nerve roots in there from the spinal cord. And so this is a very vulnerable child. We have to keep them on their stomach or on their side, because this child, we can't let that sac rupture, and we can't put any pressure on that sac. They will have surgery to close that sac. We talked about in hydrocephaly how this is a child who's got a neural tube defect genetically, not genetically, but congenitally. At the time that the egg and the sperm met, that genetic code was okay, but along the way it mutated. We had a neural tube defect. The neural tube just didn't develop right out of that gamete. And so what happened, this child is also prone to another neural tube defect, hydrocephaly, and they go hand in hand. So especially we do surgical closure and we close that spinal cord up and we put everything back in where it belongs, they're prone to increased intracranial pressures and hydrocephaly, increased fluid in their head. We talked about measuring head circumference right after surgery with this kind of patient, and then how we have to track that head circumference after when they're recovering from their meningocele to make sure they don't develop hydrocephaly if they don't already have it. So then they might in turn need a ventricular shunt, like we talked about in intracranial regulation. The far right is a club foot. A lot of children have a turned in foot when they're born, and that's just from positioning in utero, and sometimes just manipulation, range of motion, and things like that and time will help that foot straighten out. If it's a true club foot, range of motion won't straighten it out. It's a true deformity. And what we'll do is we'll work with an orthopedist, and they will, over a period of time, put them in corrective shoes and braces to begin to pull that foot outward. Sometimes it takes surgery to cure it. All right. So we're talking now about several of the things that several of these congenital defects. So congenital defect, I just showed you those because there are pictures of those. But nervous system and brain disorders usually involve intellectual disorders. We have looked at Down syndrome this semester. We looked at cerebral palsy. That's going to be a motor defect because of a nervous system problem, and then it also caused intellectual and language defects, if you'll remember. Seizures, children that are born with epilepsy and seizure disorders, Fragile X syndrome, Down syndrome, these are all things that are give the child a variety of problems, and parents are going to be dealing with a less than perfect child, might have a developmental delay. Children can be born with hearing loss or blindness based on maybe intrauterine infection or torches, like the torches diseases, the infections that cause congenital problems in children, toxoplasmosis, cytomegalovirus, herpes, syphilis during pregnancy. The metabolic disorders could be a child that like PKU or hyperthyroidism, and if we don't identify that early, it can turn into a true intellectual disorder, because those disorders can cause developmental delay and brain loss of cognition in our children. And then degenerative disorders, where children may look normal and then through life they're going to have problems, like a child that's born to a family with Huntington's chorea that has that disorder that they've inherited. That child's going to have a shortened lifespan. They'll never live to be 40. They'll probably die sometime between childhood and 20. And so there's all kinds of issues that, or maybe even 30, or it may not even come about till 25, and then they die before 40. Huntington's chorea is a really interesting disease where we may think the child's normal at birth, but if one of the parents has the Huntington's disease, excuse me, the children may inherit it and develop the disease themselves when they get to their 20s, and then they'll be dead before 40. So, and a profoundly debilitating disease during that short lifespan that they have after we detect that they have the problem. So we'll do genetic testing on these kids and see, oh wait, yeah, they do carry that gene and they're likely to get it. Okay, prenatal diagnosis of a congenital defect would happen again during prenatal care. If the parent don't have a prenatal care, then they may not know this is going to happen. It might be a sudden and traumatic event at birth, Or if it's prenatal, then they can, not prenatal, but pre-birth, then we can know that they can have anticipatory grief and be prepared for this. And the grief is determined by a lot of things. Is it a true loss or is it a perceived loss? How bad is this loss? Can we correct the defect? Like a club foot is correctable. Cleft lip is correctable. Maybe some problems along the way, but Huntington's chorea, uncorrectable and no cure. And how long that correction takes, because things like cleft lip and congenital hip may take years to repair. Okay, so we also need to talk about some of the other things like stillborn, and SIDS is later, the child's already born. Excuse me. So if the baby's born and they've got something that's likely to cause them to die within just a little while, then that's a unusual and unique challenge. A child who's born still, that they were expecting a live birth, or a child who dies in the last few weeks of pregnancy and then the mom has to deliver the baby anyway. These are things that our society views as a tragedy. Parents have been building up the birth process, and they're excited about the baby, and they prepared a nursery, and they're ready for the baby. And then instead of having a joyful circumstance, death and loss are what they're facing. So actual loss would be the baby's dead. A perceived loss is I lost this healthy baby, and it's not everything I dreamed it would be, but they still have a child. And so we want them to bond with that child. We want them to continue to care for that child, but that perceived loss may be an issue that they're dealing with. And how significant the loss is, again, we talked about that. And if we can correct the loss, whereas anencephaly is different than an omphalocele. If they've got an exposed bladder or something like that, then we can repair that. But if they have a loss of a cerebral cortex, we can't repair that. We've got a living child who won't develop cognitively. If you'll remember Zika virus from 2 years ago, that was the major viral outbreak that was happening based on mosquito bites. And we were seeing a lot of it in the Caribbean, Central America, and along the coastal areas. And so anencephaly was what Zika, if mom was pregnant when she got, or a fertile mother who was about to become pregnant got Zika, then what was being passed to the baby was anencephaly. The babies were born without cognitive ability because they didn't have higher levels of cerebral cortex present in their brain. Prenatal, again, how difficult was it to conceive? Did you work really, really hard to conceive? You had to have prenatal conception counseling, or you might have had insemination, you might have had other issues like that, and you worked so hard for this baby, and then you're born with a baby that's less than perfect. We also, if you've had a family history of congenital defects, what was your experience with that? If the parents had a brother or sister who died from congenital problem, they might believe that things are worse than they actually are because they've had such a negative prior experience. Or if they had a brother or sister with Down syndrome and the child was just very mildly impaired and they had this wonderful relationship, they might be expecting it to be really good, and it might be better or worse than their expectations. So, that history, what you've dealt with before, always plays in. How strong is their support system, making sure that they have societal support, parental support, other family, a good friend, someone they can talk to. What negative things are going on in their life. If this child was conceived out of rape, then the mother might have a different view of this child than if it was a child born out of a loving, intact relationship. So the negative elements, if the mom's been abused during the pregnancy, or if it's a birth from an abusive relationship, then there might be all these negative and these different kinds of thoughts and ambivalence towards this child to start with, that the congenital defect may be viewed as a punishment, or, I got what I deserved, or it happened because of that. And it will always be associated with that. the culture and the belief system the mother operates within also, and the father too, operates within, will impact how they deal with the grief. We talked about the spiritual support and cultural beliefs and how, what their normal expression of emotion is or not, and what kind of support and what kind of rituals they have. So some of this is very repetitive, and I'm sorry for that, but it's the kind of thing we say over and over, we just get it into your head. So to make that concept, so you can see how that concept of grief passes to all of these experiences. You can say, oh wait, this is anticipatory grief. Oh, this is an actual loss, a perceived loss. Oh, this is how the culture is going to address it. Oh, this is, it's a male or female grieving difference. So just, even though it's repetitive, keep thinking about those common themes, so that on an exam you can look and say, oh, this is a maturational loss, this is a perceived loss, this is an actual loss, this parent is grieving differently because they're male or female, or that's the style of grieving they have, or this person needs more family support, or this person needs to talk. Or keep those things in mind as you're working through the cases. All right, so parental role and expectations are also going to impact the family when a child is born with a congenital anomaly, or a stillborn child, but usually it's a congenital anomaly. Who's going to take the brunt of the responsibility for the care of this very needy child? Is it a single parent and they don't have a support group at home? Mom and dads deal differently with kids, and what is that role expectation in that family? Some families have stay-home dads, and mom is not the primary caretaker. Some families, mom is the primary caretaker. Some families that they haven't discussed that yet, and they're dealing through their own complexities of identifying role. At the same time, they're dealing with the grief process of a child who's less than what they expected it to be. Does this family have other children that we have to deal now with the other children? What does that preschool older sibling think about this child born with a major anomaly or difficulty, or maybe even being born dead, that they were expecting to be a big brother or big sister? How dependent on the parents is that child going to be through their life? Because it's a really life-changing event if you've got a child that when you're 20 is born with a lifetime dependency issue, because they will never be capable of caring for themselves. And now I'm 20, and now for the rest of my life until I'm 60, 40 years, I'm going to have to be a caretaker for this needy child. And then at the time that I pass, that child still has to have somebody to care for them. So those issues, those are lifetime issues. So the parents, they're not just grieving the loss of this child's beautiful, independent, healthy life, they're grieving the loss of their own goals and aspirations sometimes, because their life is significantly going to change. Okay, and so that shock, that helplessness, that isolation, the fear, remember all those things that happen during the grief stages are going on while they're trying to bond or deal with this loss, right? So this kind of just lays out each of these things are now are going to be talked about here. So it's I kind of went through some of the major points already. So so they have to take on the technical care, they have to advocate for their child in the healthcare system, and again, huge demands on their finances, their time, their resources, and the support for each other during this time, because sometimes they're so consumed with guilt or so consumed with care for this child that they forget to care for the relationship they're in. And again, moms often are the primary caretakers, but it may not be that case today. But these stressors on the family are going to have a lot to do with the differences, and they may be embarrassed or feel guilty, and they feel powerless because this happened and they could do nothing about it. They had no idea. If they, like a baby's born and they smoke through the pregnancy, and they have a preemie born and there's a problem with that baby, they may feel a lot of guilt about that because they were told and yet it happened. They might be embarrassed. Oh my gosh, I couldn't have a healthy child. What kind of person am I? I'm not going to share this with anybody. Might just be angry at God, angry at themselves, angry at the world. And again, we talked about the developmental level of that sibling and how the parents can help that sibling deal with the grief. And then Child dependency, we talked about it as far as the child, the parents having a lifetime of dependency on the child. But this reminds us that if a child's born with a congenital anomaly, the parents, and then they go through a series of care, like congenital heart defect, and they had a risk for death, of course, because the heart is such a needed organ. And then they have surgery and were able to restore that child to a state of health or healthy living where they can be independent. The parents may feel so vulnerable and like, oh my gosh, I almost lost them. I need to be with my child. I need to care for my child. And they can foster dependency where they don't allow that child to learn to be as autonomous as they can. So sometimes as a child's growing up, that the parental quest for dependency from that child on them, it might be a need of the parent that then fosters dependency on the child, and that child's autonomy is squelched. So we have to develop a plan, and we're going to develop based on what the parent's perception is and what the parent's abilities and their own unique culture, all those things. And so we want them to accept their child, interact appropriately with a child, participate in healthcare and learning about this child's problem, participate actively in all the child's therapies, adjust to this loss and incorporate it into their new life. And there's loads of support groups for parents that are born, parents or children, for parents of children born with congenital anomalies or lifetime deficits or with loss. There's support groups for every one of those parents. And so we need to help identify in your community where those groups are. And then at the time of the birth, or as soon as we know that defect exists, we need to be there, be present for that family, allow them to verbalize, just do a lot of listening as they talk, use our therapeutic communication. We don't blame, open-ended questions, get them to verbalize and open up. Provide support, be a liaison to support groups, be a provider of hope while still providing realistic information. And we want to do all we can to facilitate healthy bonding. Child's born with a cleft lip. It doesn't look like mom thought, but oh, look at those adorable little fingers and his toes, like all 10 little toes. Let's count them. Do the things that foster positive bonding and help the parent find the positives in that child. And so we can certainly we want to make sure that the parents understand what's going on at that time, that they understand what treatments are going to be provided at birth. If it happens at birth, like spina bifida, that child is immediately going to be cared for differently. That how the mom holds the baby has to be adjusted. How that baby lays down has to be adjusted. There will be special equipment used. That baby will go into surgery very quickly. So we need to make sure that's kind of a confusing time. So they need information and they need private time to still bond with that child. And we need to involve them actively so they feel like they're not powerless. As soon as the baby's born, there's going to be attention. The doctor's going to know, the nurse is going to know. And as the doctor's preparing to communicate to the parents what's going on, that sometimes they sense it. Wait, what's wrong? Is everything okay? How's my baby? And so they might immediately, before they're going to have that anxiety as they're hearing it. So they may not process right away what's said. And you want to be sure that your nonverbals are not negative at that point, if you're in the room when this happens, because they're going to be watching you carefully. And if you are like, ooh, making bad faces, they're going to feel like you're rejecting the infant or them or their care, and it might impair their ability to trust you. And especially if you now turn around and go, oh, what a beautiful little baby. And you're going, ooh, then, what a beautiful little baby. So watch your nonverbals. Be careful about what you express and kind of remind other people if you're in that environment. And again, emphasize the positives about the child and provide the family time. They need to bond and they need to express what they initially felt. Even if they felt, oh my gosh, this is not the baby I thought I wanted. We want them to be allowed to express that, but we still want to support the positives. We want them to ask questions. We don't want them to feel guilty about asking questions. So we don't want to be oh, this is so perfect. Your child's great. Everything's rosy when they have lots of problems. But you don't want to go, oh my gosh, this is the worst thing in the world. There's nothing good about your family. Your life is over. You know, those kinds of things do no good on either. So we're truthful, we're composed, we're straightforward, we're the professional. We're going to help them with a plan, and we're going to be the ones that point out goods. We're going to be the ones that give realistic information about the bads, and we're going to support them throughout, right? Okay, we aren't diagnosing, but if their parents are going to say, oh, look, this is like this, until the provider talks to them, or if we've called in a specialist, we can't give them a lot of information on this is how your baby's going to be. We don't know yet. We are not prognostic, not the person responsible for prognosis. And we also know that there's lots of interventions that we can do with children with developmental delays. We don't know what that child's outcome is yet, or how good or how much they're going to be able to accomplish. And so if the child's born healthy and that loss happens in childhood, it may take a while for everybody to pick up on that loss. And so they have this perfectly normal child, and then now at age 3 or 4, we notice something's wrong. It may not be that they identify that right away, and then they're still going to have that grief and loss of their perfect child, but it's going to be after they've already bonded and already they have this expectation that my child's going to Harvard, they're at the top of their preschool class, and all those things that parents go through. And then all of a sudden now we've got this new, wait, I'm at a different developmental level. And there's physical rehab, but there's also psychological adjustment that has to happen. And psychological adjustment takes longer sometimes than the physical rehab. So you might get that child to surgery and the baby is fixed, but the parents still are dealing with the grief process that they had. So there's lots of co-dynamics going on. An accidental injury, what if a child falls? They have this beautiful, healthy, normal child, and mom accidentally turns their head, child rolls off the changing table and has a head injury. Or there's a car accident and the baby's injured. So we had this beautiful, healthy child, but the parent may feel some blame and some guilt, and now they're grieving the loss of their perfect child, as well as dealing with their own guilt. And so we, again, express that, watch them go through the stages, support them, encourage healthy adjustment, talk to them about support things that are available, what's available out there to help someone with a hearing disability, flashing lights, special phones that text instead of rely on voice, with hearing impairments, that would be with visual impairments. It can be, can be Braille, there can be guide dogs, all kinds of other adjustments they can make to help them live as normal a life as possible. And again, support groups, support groups, support groups. Okay, so what do? We help with them with the anticipatory grief. We provide that emotional support. The overwhelming, the stressors that are going to unfold over time. They need help getting this child into Medicaid because this child's going to have very unique and special needs. They'll have to have that supplemental security income, SSI, that can help with the costs of the raising that child. And as that child becomes an adult, there's all kinds of programs that we can get our children in, but they are waitlisted and there's limited numbers. So we want to get them into those programs as soon as possible. So if they're waitlisted for 5 or 10 years, when that child needs it, it's still available to them. And then WIC, so they can get support for food, proper nutrition if they need it. So, and again, local philanthropic associations, things like, what's that? Adults with Disability Group, is it My Ability or something like that? We have that group here in Collin County that works with adults with disability, as it still allows them interaction, social support. It allows them all kinds of things, and they give them support as adults with disability. Coping mechanisms, we're going to see how the parents are coping, and we're going to support healthy outcomes. It's best if you don't drink away or get angry and beat away your frustrations with having less than a healthy child. When we talk about child abuse next semester, we're going to talk about the children with special needs are more likely to be victims of abuse because parents or others don't cope well. They're particularly vulnerable, and they might be viewed as the source of several problems that they're dealing with. So we want to empower those parents to deal with the children, to recognize their family strengths, their personal strengths, to build on those things, to have lots of coping mechanisms, and to have a plan for the future so they don't feel powerless. They feel like they have some control over the situation, and what they do can help. All right, so again, they're going to go through the stages. So shock, short term, let them verbalize, no, it can't be. Just be there for them. Just be there for them and help them as they begin to, oh, it can't be. We want them to begin to set a goal, begin to think about what can I do to help? Because that will promote them moving into the next stages of grief. Adjustment, there's things that parents can do that aren't always healthy during that period of adjusting to the illness. Again, they may overprotect that child and delay that child's skill acquisition and autonomy. They may reject that child, and then the child will be verbally abused, physically abused, or emotionally detached and not develop a good bonding relationship, which in turn will affect that child's ability to function in their life because they have to deal with Erickson and all the Erickson stages growing up, and that's partly dependent on the parent-child relationship. They may deny the child had anything wrong, and they'll spend the next while, as they're adjusting the illness, they'll be in a pretend world where everything's fine with my kid. I don't know, what are you talking about? There's nothing wrong with this child. Or the acceptance may happen over time, and they need realistic restrictions on the child and self-care. So a gradual acceptance is the most ideal of this adjustment. Most parents, the baby's born, they go, oh, great, I have a child born with this, and they accept it immediately, and they're totally ready to deal with it. That's not really the typical situation. There's usually all that anticipatory grieving if they're blessed enough to know ahead of time. And then there's the gradual acceptance of what's going to happen. And then the child's born, and now we really know what's happening. And over a period of weeks and months, they begin to accept, and even days and years, because at 2, the child's supposed to potty train. And now we find out if they're able to do that or not on a timely manner. And they are continuing to have an unfolding acceptance of what's going to happen and how they're going to deal with each stage of that. And then reintegration and acknowledgement. So they're now this child is going to broaden the world. They're going to be looking for support groups. They're going to be looking for churches that have activities for a child with their particular disability. They're going to reintegrate into society, but they need a friendship and a support group that understands, not one that's critical or judgmental. They want to, they're going to develop friendship groups where the kids come over and they're going to play with that child and not make fun of or whatever. So reintegration into a new life, and it might change the support system, it might change the friendships, all those things for this child. So then we talked about support systems, certainly, community resources, we already dealt with that. Okay, and then the parents need a lot of education, general health care for a baby anyway. Parents have to learn about if it's their first child, and then how this child is going to go about getting their activities of daily living met. At first, they'll be totally dependent on mom until we see if the child can get some autonomy. We need to they need to process safe transportation for the child. They might need a special van, handicap kind of setup in their van that will adjust to a wheelchair or special adaptive devices. They might need braces and things for the child can transport themselves as well as participate in their ADLs. And they're going to need primary health care. That child's going to need a doctor that's their primary provider that understands their illness. Then the supporting the family's coping, and they might need help with supporting not just the child, they might need help just supporting themselves, but supporting each other. And having a child who's stillborn, or a child who dies of SIDS, or a child with a congenital anomaly, that spurs a lot of divorce in our country because of the grief, the blame, the guilt. So that parent-to-parent support becomes very important at this time if we don't want the family to dissolve, which could then make each individual person in that family more vulnerable because it narrows their support group. So again, emphasize the ability, help them deal with the siblings, refer to resources, and then evaluation will be, oh yes, you met all your stages of grief. All right. They talk here about how important it is to talk to both parents at the same time and foster an honest discussion at that time. It builds trust if you don't talk to one and then the other, and they think maybe you told something different to the other one. You really want them to have trust in the healthcare providers and to appreciate the reality that this is real, that this fantasy of the perfect child is no longer going to happen. It's important that they begin the grieving process. We know that the burden could come on primarily one parent, and so we want to talk about, and not in the initial conversation. We're not going to talk about the financial needs and things like that in the initial conversation, but we want to help them process that thing quickly after the diagnosis, because we know there's going to be increased burden. So the first thing out of my mouth isn't, oh, your baby has cleft lip and it's going to cost a lot of money to fix it. But we want them to begin to process that, and then pretty quickly we want to let them know there are treatments. This is what's going to take. This is how much support this child's going to need, and then think about this. Are they going to be afraid to get pregnant again? Are they going to be afraid to have future children? And that might be justified based on what else is going on in the life, and if it's a familial thing and it's likely to happen over and over, or it might not be justified. It might be an isolated thing. So again, we talked about parent-to-parent support. And one of the things is getting respite care for these parents. If you're at home all day long caring for a child with cerebral palsy or with profound developmental delay from whatever reason, then sometimes those parents need a break. So parents' days out, finding respite care, a provider that can come in that understands that child's special needs and can be there for them and help them with that. And then all the special equipment they need. There's vendors, there's support groups, there's philanthropic groups that will provide things for families. So we really want to help them work through all those things. Okay, and we're going to advocate, right, for your patient. Reimbursement for travel care, child care, plus stipends to enable the parents' voices to be heard at meetings. So we're going to advocate for them with every support group, you can get them involved in these national groups that are promoting awareness of the disorders, and they can help them with support. We need to know if there's legislation going on that will help children with special needs and let them get involved in whatever action it takes on their part. So all those things allow the family to be empowered, to feel like they're participating in a cure, they're participating in a positive outcome, that they are doing something positive to help their child. And then again, the sibling may have less attention paid to them. So we want to help the family process, that they still are caring for the other child, that other child doesn't feel like they're left out or they're not as important. And that child is going to have questions and be grieving too. So again, guidance for the family as they help their other children through the process. Okay, stillborn. Born still is stillborn. That's right. A stillborn child, we have all these different definitions. Neonatal death is death that happens in that first 28 days of life during the neonatal period. Stillbirth is actually late pregnancy loss. You're after the age of viability, after 20 weeks, and then between 20 and 38, 40 weeks, the baby dies. A miscarriage is usually an early pregnancy loss where the baby dies and they lose the pregnancy in the earlier trimesters. An ectopic pregnancy is still considered a perinatal loss. It's not stillborn, but the mom gets a positive pregnancy test. Oh, I'm pregnant. And then all of a sudden we discover, wait, the HCG is growing. There clearly is a pregnancy, but the baby's not in utero. There's an implantation on the intestine and bowel wall surface of the uterus, wherever it may have implanted. Stillbirth, and again, stillbirth, loss after 20 weeks. So we reach the age of viability. We're going to have a healthy baby. Yay. Then the baby's lost. About 1 out of every 160 pregnancies. Most happen before labor. Every once in a while, it does happen during labor and delivery. So the baby dies in utero during the labor process. So they come into labor with what we think is a healthy baby, and then something happens. So stillborn, there's this healthy life they were anticipating has a very unique meaning for these grieving parents. They've lost a part of themselves. You know, when that baby's growing in mom, there's a whole self-esteem thing there. I can have this healthy baby. Now I can't have this healthy baby. I failed as a mother. I've lost a part of myself. My family name won't go on. The immortality of spreading my genetics to future generations isn't going to happen. Not that that's not ever what I thought when I was pregnant, but there is a real deal about, you know, the family name being carried on, family genetics being carried on. There's a sense of emptiness, a sense of failure. I couldn't do it. I couldn't be a healthy mom. I couldn't be a healthy dad. Then they might have disenfranchised grief because the circumstances that cause the stillbirth might be something they can't talk about, you know, and that society doesn't accept or society blames them for. They're more prone to have postpartum depression, more at risk for postpartum depression. And we talked about the reasons for postpartum depression back in Mood and Affect, and about how congenital anomalies and stillbirth and problems with the pregnancy were things that made them more at risk for that. So the severity of grief, no matter what gestational age the baby is, can be the same. The loss of a baby at 5 months is just as devastating as the loss of a baby at 7 months. So again, we talked about most of this already. So what causes a stillbirth? Well, the older the mother is, the more likely they are to have this, or the very young mother, the very old mother. Those are our two high risk groups, right? The development of a placental problem and the awareness that there's not adequate placental perfusion, like abruptio or significant previa, may rob the baby of essential nutrients and cause a stillbirth. A birth defect that is developing in utero, congenital defect in utero, might cause a problem with stillbirth. Growth restrictions, the children that aren't developing in utero, that aren't growing appropriately. Torches and other infections are likely to cause this. A mom who's a substance abuser is very often has a stillbirth circumstance. Umbilical cord, you guys talked about things like the umbilical cord being wrapped around the neck or the umbilical cord being damaged, trauma, like where mom gets hit in the stomach or in a car accident. Maternal diabetes can cause a stillbirth. Maternal hypertension, you know, we talked about the toxemias of pregnancy, and we usually go ahead and try to induce a labor if the child's of a good viable age, because we recognize the seizures can cause decreased perfusion and damage and injury to the child. And then a post-date pregnancy, you know, the post, you know, after those born at 42, 44 weeks, those are more likely to have a stillbirth. Even though we think we know why, about a third of all stillbirths we don't have a cause for. So we talked about each of these things already: growth restrictions, fetal death, stillbirth, accidents, okay, all those things we already just talked about. So mom's response to loss. The parents had a stillborn child. What's usually happened? All those physical, cognitive, emotional, behavioral effects of grief happen here. The headaches, the palpitations, shortness of breath, insomnia, nausea, dry mouth, they feel emptiness. a hollow feeling in the pit of their stomach, fatigue, oversensitivity. I just can't make a decision, cognitively disbelief, confusion, inability to make a decision, hypervigilance. That's the stress response. Repetitive storytelling, they're talking over, saying the same thing over and over and over and over. That's processing. It's processing. It's not bad, but we need to expect it. Difficulty to concentrating when we want them to, and so they're like they'll be frustrated. I just can't get that done. I just can't concentrate. I read the same paragraph 17 times. That's a stress and grief response. Emotionally, they're going to be anger. They might have guilt. They might be numb, that denial, numb feeling, indifference and apathy and it's just because they're still processing feelings. So they don't feel anything. And then spiritually, they might be angry at God. They might turn more to God. We don't know. They might feel a lack of meaning or direction, where they might wish to join the deceased. They might become depressed and be high risk for suicide. So you need to watch for that. They might feel betrayed, hopeless, and they might assign they might say, "Oh, my baby's now in an angel in heaven," or "This is God's will," but it just depends, or "I'm punished for something." So it just depends on their spiritual approach. So what do we say, what do we don't say when a baby is stillborn? Because sometimes we can say things that are supportive, hopeful, and provide guidance, and sometimes we can say things that really aren't helpful. So good things to say: "Oh, do you see a family resemblance in your baby? He looks just like his daddy. Your baby's beautiful. What have you named it? This isn't what you expected. I'm so sorry. I'm here for you." But don't say, "Oh, you can always have another child. Oh, you have an angel in heaven. It was for the best. It just wasn't meant to be. It was God's will that this happened." That is for the parents to assign if they believe that. Or when was the last time you felt the baby move? That may be like, "Oh, you should have noticed this." Okay. As a nurse, if we know, like, okay, so your mom's in labor, you're got them on the monitor, you got the heart rate monitor, you know something's wrong, right? So our job, helping prepare the patients, knowing what the parents' desire is for this baby. What are we going to do? Some parents want to get the baby, name it, hold it, and bury it. Other parents don't. So we're going to support the parents, whatever that decision is. We're going to stay on, are they going to stay on the mother baby unit where the other babies are? Or are they going to move off the unit? And that's up to the healthcare provider and the parents, right? And we're going to provide, of course, the end of life care. That baby is going to be cared for as a deceased individual, right? They've got to be tagged, and they're going to be, depending on if autopsy is required or not, we're probably going to call the morgue to pick up the child at the funeral home, depending on the kind of hospital you work at. Going to wrap the baby, bathe the baby, going to let mom hold the baby, have that time with the baby, take pictures of the baby. They may not want those pictures right now, but they might come back in a month and want them. And then we need to talk to them about processing the grief and going through that process before they attempt another pregnancy, so that emotionally they're in a good place. And then we need follow-up care, bereavement counseling, support groups, and we need to make contact with them. You don't want to just dismiss them and nobody ever contacts them again. They need follow-up phone calls. So again, stay with the parents, give them private time alone with their baby, recognize how mom and dad are grieving differently, recognize them, support that, let them know what they're doing is okay, it's normal. Again, take a family portrait and photograph the baby. Create a memory packet for this baby. The baby's footprints, the baby's picture, all the little doodads that they get at birth that they take home. You want to encourage them to name the infant, and you want to start discussing, they're going to have a discussion about funeral arrangements, and that's going to happen fairly quickly. So who do we need to call? Who do you want us to call? And then if they have to have an autopsy, then that we're going to consider their cultural influences and how that's going to impact them, because quite often an autopsy is required, especially if it's a traumatic reason that the stillbirth happened. or if it happens during the hospital care, autopsies may be required, unexpected death while they're in hospital. Organ donation, do they want, this baby was born, do they want to donate skin or tissues? And then if they do, we can harvest those things. And give the family a number, a hotline that they can call anytime that they have a question, a support person, so that when they go home, they always have a hotline to call. NICU, those oftentimes, the baby's born and then they're rushed off and the baby wasn't stillborn, but they have neonatal death. So it's happening hours after birth. They're rushed off to NICU, and the NICU nurses do everything they can to save the life of this baby, but they're unable to. So a lot of times the NICU nurses are the ones dealing with it. So neonatal birth, the NICU nurses are going to deal with it. If it happens during labor and delivery, then the L&D nurse is going to be the one caring for it, and the postpartum nurse going to be dealing with the mom's grief process over time. A lot of times we're going to keep the baby warm and comfortable and close to the bedside of the mom if the mom wishes this until the time of death. If we know it's going to die no matter what we do, we're not necessarily going to remove them from the mom's care. The mom may want to see him, they may not want to see him. We usually keep that baby warm and wrapped for a little while in case they change their mind in an hour they want to hold their baby. So we have to be prepared for that. So we're not going to haul that baby off within 5 minutes. We're going to, the baby's born still, and so we'll wrap them, keep them warm. And mom said, no, I can't handle holding them. And then 45 minutes later, she's sobbing and she decides she wants to hold them. We need to be prepared for that. So does she want to be around crying babies and postpartum moms oohing and eyeing and looking at their baby in the nursery? Maybe not. Maybe we need to move her off the neonatal unit. So, but if mom is postpartum, she needs good postpartum care. And so we want to make sure the staff, wherever she goes, is prepared for that, right? All right. If the baby is born dying, sometimes the mom may want that baby to die in their arms. So, okay. We want them to be given an opportunity to be parents, touching, holding, caressing, private time with their infant. They may want to, even after the baby's died, they may be the one who wants to bathe it. They may want to dress that baby. If they're hesitant, like I said, you want to keep him in the unit for several hours to let the parents change their minds. And they may want to say hello, and then they may an hour later want to hold that baby to say goodbye. And so if the body's already been taken to the morgue, you can go get that baby, rewarm the baby with blankets and a warmer, and then take it to the parents. It takes a while for the rigor mortis to set in. So, if it happens within an hour or two, we still can go get that baby. And again, the photograph is important because that might make this a more tangible loss, and it helps them accept it. Again, the nurse that's had the best relationship with the family should be the one present during the discussion about the death. It's usually the provider, but also a nurse will usually be present as well. And that way we're in on what they said, so we don't give conflicting information, but we also are there for the family. Someone in NICU should take the responsibility for getting the information, helping, providing them funeral homes if the baby's in NICU, give them what services that funeral home offers. Will they pick the baby up? Do they want a funeral? Do they want burial? Do they want cremation? What do they want? Get the clergy involved. And then again, the memory packet we talked about, it encouraged naming. All right, and the photograph may be important later, so we definitely want to photograph the baby for them. Support groups, compassionate friends, amend, and then there's some links to websites that can be helpful for families dealing with loss, neonatal, and stillbirth. You were born silent, perfect and beautiful, still loved, still missed, still remembered every day, stillborn, but stillborn. I'm going to stop the share here before we do sudden infant death. I'm going to stop this and I'll come back and do a second video for you.